Hello again, and welcome back to HealthWatch. I'm June Baker, and I'll be your host today. As always, we have a wonderful show planned for you today. Our first guest is Dr. Eduardo Zambrano, who's a urologist and surgeon with Novant Health Urology in Wilmington. Then we'll meet Antoinette Izzo, a physician assistant with Novant Health Pulmonary Medicine in Philote. And lastly, we'll hear from Sarah Arthur, Director of Community Engagement for the Novant Health Coastal Region. So stay tuned to learn about this and other topics on HealthWatch. Please welcome my first guest, Dr. Eduardo Zambrano, who's a urologist with Novant Health Urology Partners in Wilmington. Dr. Zambrano, thank you so much for coming today.
Thank you for your invitation. I appreciate it.
Sure. I know how busy you are, so I'm going to make this really easy for you.
Okay.
So you can go back to work. So I always start with getting to know my guests a little more and letting our viewers know where you went to school and where you're from. Where did you grow up?
So I actually grew up in beautiful Medellin, Colombia, so South America. Good coffee, good people.
Good people.
Fun places. So, but I was seeking for better educational opportunities. So I came to the States when I was 16 years old.
Really?
So I would say I finished my high school and my college in New York. But then I worked as a research technician and assistant at the National Institute of Health. I was very interested in medicine from the beginning.
Oh, that's awesome.
So I knew I was going to go to medical school, so I wanted to sort of be in the research sphere and get good recommendations and be sure about sort of what the focus would have been once I would finish medical school. So I did spend some time in Bethesda at the National Institute of Health.
That's a pretty amazing background.
Yeah, and then so I did my medical school at the University of Pennsylvania in Philadelphia, and matched for urology there as well. So I was in Philadelphia for 9 years. And then I came down south because I met my wife during medical school, and she was from UNC Chapel Hill.
Oh.
So we ended up doing our post residency training in oncology at the University of North Carolina, Chapel Hill.
And she's a physician too.
And she is, yeah. She's a gynecology oncologist. She's also a surgeon.
Oh, wow.
So it will be cool because we'll be probably working together in some
that's
cases.
true.
Yeah. So she's
Especially
part
in
of
the
the center.
oncology piece, yeah.
Exactly. So
That's awesome. Well, we're really happy to have you here. We're glad that you chose Novant Health for your home. And it's going to be exciting for us. It's a great resource that we need. There's a shortage of urology here, and so
yes,
we're very happy to have you.
us as well.
And what drew you to the coast? Is there something, do you have family here?
So not particularly coast, but North Carolina. We love the
see.
state, and we spent 3 years in Chapel Hill.
Oh, yes.
And my wife is originally from Pittsburgh, just outside of Chapel Hill. I'm a city person, city boy, but always appreciated the countryside and the ocean. So this was a great opportunity, and we knew we wanted to stay in the state. So we were pretty excited to find jobs. Both of us will be working with Novant in Wilmington.
Right.
So
It's a big facility.
yeah, big facility, and for cancer surgeons, great because the Zimmer Center, it's a very
I love
robust
the Zimmer Center.
cancer institute, and they're really good connections with UNC. So what was exciting for us coming through our training and finding our first jobs was that we will have the opportunity to collaborate with UNC and other institutions, and there's this partnership that's being built in the process to do clinical trials here between Zimmer and UNC Lineberger Cancer Center. So we will be sort of part of that, and that's our, within our goals, short-term goals, is to figure out how to connect with UNC and bring good research down here to Wilmington.
Yeah, it's a win-win for everybody, but especially for our patients.
Yes.
Yeah. Well, I know that cancer surgery is a big part of what you do, and you do a lot of robotic surgery.
Yes.
So tell me what value the robotic surgery brings to a patient or to a physician.
Sure. I think, the big selling point about the robot is that definitely decreases pain, postoperative pain. And also for a surgeon, you can use it in a way that you can basically see better and dissect their planes better, so you minimize blood loss. So it will be pain control after the surgeries and then minimize blood loss. So that translates into faster recovery. Usually, depending on the type of organ surgery that you have, so let's say in my field, kidney and prostate, or smaller tumors in the retroperitoneum, you can easily go home by next day. And that's because, that's because you just basically, pain it's very minimal. In general, you don't really need narcotics after robotic surgery.
That's great.
In general. And then, yes, blood loss is minimal and it's smaller incisions too, so that affords faster recovery. So you can be home more comfortable rather than hospital faster. So, and the outcomes are very similar, and what we care about is oncologic outcomes, so that we achieve negative margins, so that we remove the whole cancer. So, people who are against the robot, and I will say that's an older generation, they're always like hesitant to
really
adopt
you have to talk them into it sometimes.
But but I will say, at least in urology, it's widely used by now. In 2022, I will say at least the prostates, 95% of prostatectomies are done with the robotic platform. Kidneys, many of them we can now, because we gotten really good at it, we can do more complex tumors and use the robot. And again, the goal in the robot is minimize pain and enhance recovery because you have very minimal blood loss.
I want to concentrate a little bit on prostate cancer. How prevalent is it?
Extremely. It's the most common cancer in men, and it's interesting because people don't really recognize that. There are myths about prostate cancer. So
really?
It's very common. People decide not to, I don't know, there's a little bit of controversy about prostate cancers because the way we did screening before, and I'm referring to PSA, which stands for prostate-specific antigen. Basically, we didn't know how to really interpret those results well, and then we overused how we're approaching diagnosis. So ended up being a lot of overdiagnosis and overtreatment. So so it sort of got a bad rep. So for a while, some of the non-surgical societies wouldn't really recommend PSA screening, like routine PSA screening. So we come to an agreement, and it's extremely important because it's the most common cancer in America for men, and it kills a lot of men as well. Luckily, most of the cancers are detected early, but that's why you have to be aware about PSA screening.
Yeah. Does it affect a certain age group? Or?
Yeah. So most people. So it's one of the myths is that it only affects older men. Almost true, not quite. Actually, about 35% of men will be under the age of 65, which I consider young.
That's young.
Yeah. So, and if it presents earlier and earlier, those tend to be more aggressive. So what we saw with the old PSA controversy and decrease in the use of PSA screening is that now we started to see more advanced disease in younger men. So it's known, it's a known effect from all this, controversy around PSA screening. So it's important to keep that in mind.
So you also treat bladder cancer?
Yes.
Tell me about that. What surgical procedures would you
So it all depends how, the tumor itself is affecting the wall of the bladder. So we care about depth. So if it's superficial, it's not into the muscle wall. So the bladder has three basic layers of mucosa. There's the inner lining. Then you have your muscular layer, and then you have a fatty layer with fibrous tissue, and then that's it. So if it's affecting just the superficial, you can do that via endoscopic procedures where you just sort of scrape the bladder, and then depending on the pathology, we're looking for low-grade versus high-grade looking cells, so how aggressive cells look under the microscope. Then we would recommend doing intravesical treatments where you put an agent in the bladder, like a chemotherapy or a like, to minimize the risk of recurrence. If it's into the muscle, then unfortunately the bladder has to be removed, because once it's at the muscle, it can get out and metastasize very easily. So you need very major surgery. Well, you have to remove the bladder.
I wanted to touch on renal cancer before we run out of time. Tell me about how you treat.
Yeah, so it all depends. So nowadays we find a lot of renal cancers because of CT scans. Everybody goes to the ED for, I don't know, abdominal pain, gets a
Right.
CT scan.
Yeah.
You know, you fell, minor bruise, CT scan.
Yeah.
So it's very overused in the US. So now we're finding all these small renal masses.
Oh.
In general, they tend to not be aggressive cancers when they're that small. Maybe 20% of them will actually be benign. So people really freak out about these small renal tumors. So if they're small, active surveillance, basically you do serial scans is one of the approaches. Depending on the size, then we actually recommend removing, but we don't have to lose the kidney. Now with the robot, for example,
gosh.
we're able to partially do a partial resection of the kidney where you only take the tumor and save as much kidney parenchyma as you can. So,
That's amazing.
so we can do a lot with the robot, but if it's a big tumor in the kidney, then the kidney unfortunately has to be removed. So it all depends.
But you have 2 of them, right?
Yeah, but you have 2 of them, exactly.
I shouldn't have said that. But yeah, that's great news that you can do partials and you could live a long and productive life with 1 or 1.5 kidneys.
Yeah, I would say you only need about half a kidney.
Really? Well, that's
Yes,
good to know.
Yeah, so there's room for having some surgeries.
Well, it's been such a pleasure having you. I hope you'll come back because I think there's just so many more questions I have to ask you that we would love to have you as our guest again.
Oh, thank you. Yeah, I'll be very glad to come back.
All
and
right.
chat,
Well,
so.
thank you so much for being here. We enjoyed getting to know you and hope to see you soon.
Well, we'll do. Take care. Thank you.
Thank you. Please welcome my next guest, Antoinette Izzo, with Novant Health Pulmonary Medicine in Charlotte. How are you today, Antoinette?
I'm doing well. Thank you for asking.
I'm so happy you're here because I have a personal connection with sleep apnea. Having it in my household, it can be very annoying. So before we get into that, tell me a little bit about your background, your education, and what brought you to be a physician assistant and specialize in sleep medicine?
All right. I started in undergrad at North Carolina State University, and a few years later decided to go to PA school and was able to attend East Carolina University. And very recently in May, I actually graduated with my Doctor of Medical Science from the University of Lynchburg, so that's very exciting.
Oh, that is exciting. Congratulations.
Thank you. And I started my work as a PA in Columbus County in the emergency department, and I had a small child at the time.
Yeah.
I felt like I needed some different hours, and so I was able to join the practice in Wilmington in 2006, and I have been working in pulmonary and sleep since then. Initially it was pulmonary and sleep. Now, probably since 2008, it's been mostly sleep.
Sleep. Yeah, I know that you were several years in Wilmington, and then you recently started seeing patients in Charlotte, and that's such a beautiful office.
It really is.
Yeah, it is great, and that's part of our new Novant Health Pulmonary Medicine in Charlotte. So let's talk about some of the conditions a patient might be seeing pulmonary for. What might that be?
The most common pulmonary conditions would be COPD, asthma. We do see people for lung cancer, for infections in the lungs. So those are the pulmonary conditions. And of course, the pulmonologists and me and the other PAs and NPs see patients for sleep. And so the sleep conditions, mostly sleep apnea, but then of course insomnia, that's a common one as well.
Oh, really? Will you do pulmonary function tests at the Charlotte location?
We do. So we have
That's
a
great.
fully functioning pulmonary test there now. And of course we can get x-rays and CAT scans if needed to review before the patients come in. So all of that is done locally.
Do you do the pulmonary function tests or?
No, one of the nurses does it.
I see. So they have, that's nice that they have the unit there.
Absolutely.
Yeah. Well, today I wanted to focus on sleep medicine because that is your specialty. And I can't tell you how many people I've talked to who go, oh yeah, I wear a CPAP. There are so many people I know.
Yes.
What are some of the signs that you might have to indicate that you have an issue?
So I would say the most common things are people will say despite sleeping a normal amount of time, they are waking up not feeling refreshed, and they might get more tired than they think they should during the day. But truly the most common thing is someone's being told, you need to get help because you are making a lot of noise, and the bed partner leaves the bedroom because they can't stand the noise. So that's the number one reason people come in. Yes.
So either their wife or their husband or their partner says, you're either snoring or something's going on, and I can't sleep with you anymore.
Absolutely. That's what motivates people.
That's what my audiologist says. Usually it's the partner who says, you can't hear, you need to go get your ears checked. So similar thing. So are there different types of sleep disorders? There
are. So there's even different types of sleep apnea. And so there's different sleep apnea types, different...
Really? I didn't know that.
There are. So the most common one that you hear about when we're educating the public and doing health fairs, things like that, is obstructive sleep apnea.
Okay.
But there's a type that's called central sleep apnea. And that has to do with the central nervous system. Okay. It's a signaling problem. And there's complex sleep apnea, which is both kinds of sleep apnea kind of combined. It is. And then, of course, with insomnia, there's not really different types of insomnia, although insomnia can be temporary or chronic condition. And so we do treat it differently, depending on what it is.
No. So how do you actually diagnose somebody with a sleep disorder? And does everybody need a sleep study?
You would think everybody needs a sleep study, but they don't.
Oh, I didn't know that either.
So there are people who come in for a consult, and after I speak with them, I'm able to determine that they really don't need a sleep study. So it's rare because we have such great people who are referring patients in, that they really refer the folks who need the studies. So that's the issue. So they're just good at referring. And so when people come in to see me, one of the big decisions I have to help them make is what study is going to be appropriate. So you may or may not know, but we do studies in our facility here at the Brunswick Medical Center.
Right.
And we also do them at home, and that's part of why I need to do a consult with patients to try to figure out, which study is appropriate.
Wow, that's a lot of information. Let's talk about devices, CPAPs or whatever. How do you treat this? What's that?
You're right. The most common treatment is CPAP, and so that is the little mask.
I only know that because my husband wears one.
Yes. So that's a mask that people wear that's attached to a little air pump, and the air pump blows air into the throat to help it stay open so that people breathe normal. So the second most common treatment we use is a mouthpiece. It is custom fabricated by dentists who are trained in sleep medicine. And it just moves the bottom jaw a little bit forward to open the airway. And then we have a newer treatment that we've been using, 2 or 3 years now. It's an implanted device, and it actually stimulates the tongue to move forward.
Oh, really?
Yes. And it's reserved for the moderate or severe sleep apnea patients who cannot tolerate CPAP.
Wow. I can't wait till you come back because I have some more questions, but we're out of time. So, again, you're in Charlotte.
Yes.
And we can run your phone number on the bottom. You're taking new patients, right?
Yes, we are.
Okay, that's great. Well, will you come back and talk to me more about sleep?
I'd love to.
It's a great topic, and there's so much to learn.
Yes, I'd love to.
All right, thanks again for being here today. We really appreciate it.
Thank you for having me.
You're quite welcome.
All right.
Please welcome my guest, Sarah Arthur, who's the Director of Community Engagement for Novant Health's Coastal Region. Thank you so much for being here.
Thank Thank you.
Good. I'm so excited to have you here because community engagement is near and dear to my heart. Yet I don't know what all it entails. There's a lot more that goes on than just having events. But let's start with your background. I always like to introduce my guests to the community. So tell me about your background.
Yeah, I grew up in Greensboro, North Carolina.
Did you?
I moved to Wilmington about 10 years ago. I got my undergrad as a social worker at Appalachian State. I hope everyone saw the game recently.
I did too. My granddaughter goes there. So it was really exciting.
And then I went and got my master's in social work at UNC Charlotte. So I started my career in social work helping homeless families and doing therapy, and then moved into managed care with Trillium, our local MCO. And then started working at New Hanover Regional 8 years ago, and then transitioned over after the merger with Novant Health.
Wow, that's interesting. I didn't realize you were a social worker. Yeah,
Yeah.
that's a great background to have in community engagement.
Yeah, it's a good perspective, I think.
I think it brings a lot of value. I understand you were in case management.
Yes, I started my career in case management. I worked on progressive care unit with a lot of stroke patients or patients on a ventilator. Then moved over to the med-surg unit where we had a lot of patients that were struggling with either a mental health or substance use disorder and had a subsequent medical need related to that. So I really enjoy working with that population. I have some personal experience with family members and substance use, so they're near and dear to my heart, and I feel like it helps to have an advocate for them.
It does.
And that's what I really enjoyed doing when I was working one-on-one with patients. I moved into overseeing our whole social work team. We had 26 social workers at the hospital in all different areas. It's so exciting to see what social workers can do and work with physicians.
Yeah, it's so different now.
Yes.
For social workers.
Yes.
And they're so important to our facility, I know. But in general, I think they're one of the most important people in a hospital.
Yeah, they're often overlooked when it comes
I
to
know.
thinking about discharge or thinking
know.
about grief and loss.
Yeah.
There's a lot that they're there for that sometimes the physician or the nurse may have already left the side of the patient.
Right, yeah. So from there, you shifted to community engagement. So what does community engagement mean, and what is the scope of your department?
Well, we really try and focus on the mission of upward mobility and health equity for our community. So we have 3 different pillars. We have a relationship engagement piece focused on charitable contributions and sponsorships to local nonprofits, and those partnerships where we're making connections in the community and with our local hospital on how we can serve patients. We also have a pillar of community health workers, so they are...
Yeah, I'm interested in that.
They are individuals with lived experience that go into patient homes. So when I say lived experience, I mean that they themselves have been on Medicaid or may have grown up in public housing.
They kind of know the system.
They do, and they've overcome
and
those
they
barriers.
speak the language.
They can truly build rapport with a patient compared to a social worker or a physician or a nurse. And they really meet someone where they are. And I think being in a patient's home also makes a really big difference.
And so that falls under community engagement.
Yeah, we have about 9 community health workers, some with different levels of expertise. We have 2 bilingual community health workers, perinatal, one that focused specifically on elderly patients. So,
and are they tied to primary care in some way? Or are they?
Some of them are. We try and partner with Novant Oceanside here in Charlotte as one of our practices, and then a few in the Wilmington area that have a high majority of patients that are on Medicaid coverage, because we know that there are often some other barriers that comes with that population.
I didn't know we had perinatal.
Yeah,
I didn't know we did
she
that.
also is paired with 2 doulas.
Oh, nice.
Yeah, so they are with the patient, throughout their birth. They go help them in labor. And
Oh,
then
wow, that's awesome.
Yeah, they follow for a year after birth as well.
Wow. And there are how many of those folks?
Two doulas and 1 perinatal community health worker, and then 8 other community health workers.
Wow.
Yeah.
That's really interesting.
And then our other pillar is community health services. So that's going out to health fairs,
Okay.
doing health screenings, trying to really push preventative care with individuals so they know what their numbers are and they feel empowered to take control or possibly prevent a chronic condition like diabetes or hypertension.
So today I want to talk about food boxes. I heard that Novant Health provides food boxes at some of our physician offices. So is that sponsored by community engagement? Is that how that works? And where do the food boxes come from? How do we come up with those?
It's a really exciting program. It started in 2019, and it was originally a grant with the Blue Cross Blue Shield and a partnership with the local food bank. We are really dedicated to addressing the social determinants of health for our patients, so that includes food insecurity, housing, transportation, interpersonal violence, financial strain. So our nursing team, either in the hospital or at a physician office, will ask 2 questions for a patient around what we call hunger vital signs, and it relates to whether they've had enough food in the past year or whether they need food today. And it's sad to hear how many people don't have food for that day. Often, I think we know people choose to buy food over medicine sometimes, or vice versa.
Yeah.
So we provide a patient with a food box of shelf-stable food. It lasts about 7 days, and then we give instructions on how they can look at sustainable supports like SNAP benefits, or most people know them as food stamps, or local food pantries.
Yeah, and there are a number of local food pantries that, and that's a good way to educate people about the food pantries.
Yeah, and they're wonderful partners too. I think food pantries touch people in a way you don't realize sometimes.
They do. I wanted to touch on the health needs assessment that we work on every year. Tell me about what is your role in that?
So we partner with the local health department and then Dozier Memorial Hospital on a community health needs assessment. And the goal of that is a large survey looking at what does our community think we need. I love it because getting the most community feedback we ever get in one setting. And this year we got over 700 responses. And in that process, we look at the data.
That's more than I think we've ever done.
It is. It definitely is. Our community showed up.
I used to have to work on that.
And we'll work on a hospital plan as to how we want to address it and what we have control over in terms of addressing those needs.
And how often do we have to do community health needs assessments?
We do it every 3 years.
Wow.
Yeah, and we really enjoy being a part of that.
Yeah, that's great. Well, Sarah, this has been so amazing. I've learned so much today, and I hope you'll come back and join us again sometime.
Yeah, of course.
I just think you have so many stories to tell, so.
Thank you so much.
Thank you. Thank you for joining us today. I hope you enjoyed the show. If you have any questions or if you're looking for a new physician, please visit our website at novanthealth.org. I also want to take this opportunity to remind our audience that October is Breast Cancer Awareness Month. So please call Novant Health Scheduling to reserve your appointment to have your screening mammography. If you're uninsured or without means for payment, there's no need to worry. Novant Health has resources to provide free mammos to those who meet those criteria. So please schedule your mammo today. It could save your life. So thanks again, and we'll see you next time right here on HealthWatch.